endocrine pathology, hypopituitarism. So for hypopituitarism, we're going to see a couple pathologies that are important, and I'll outline them very quickly. The first one is going to be Sheehan syndrome. What we see with Sheehan syndrome is ischemic infarct of the pituitary. Okay, so the whole entire pituitary has a decrease in oxygen, and it causes infarct within the organ. Okay, and the reason behind this, the main cause of this, is after pregnancy. So I should say during pregnancy, you can have severe postpartum hemorrhaging. Okay, so after you're pregnant, or while you're pregnant, or while you're delivering, I should say, you bleed a lot. That leads to an overall decrease in blood volume. And when we have a decrease in blood volume, then we're not going to have enough blood circulating around. And we tend to have a decrease in the amount of blood supply that's being delivered to the pituitary gland. And the pituitary gland is going to be actually increased in size secondary to the pregnancy process. So it actually needs more blood flow than normal. So if you need more blood flow than normal, there's more O2 demand at the pituitary, but now you have a decrease in circulating blood available, then it leads to an infarct, ischemia, and then an infarction of the pituitary. And that's very important, okay? And so what happens is that you're going to have an overall decrease in production of the pituitary hormones, all right? So if you ever see a patient that comes to you, and the vignette is going to be very important to identifying Sheehan syndrome, but the patient's going to come and they had pregnancy about a couple months ago, maybe a month ago, or a couple weeks ago, and they said that there was severe postpartum hemorrhage after the delivery, and they're not able to lactate properly. Okay, so they should be still lactating, okay, a month or 2 months after delivery of the child, but this patient is unable to lactate. Okay, very important. They love to ask that. They also have severe fatigue. They have amenorrhea, so they're not having their period. And they also are very cold, okay? So keep those in the back of your mind. If you see a patient that was pregnant, during pregnancy, she lost a lot of blood, and then she's presenting to the office either with she can't lactate and she's so fatigued, she's much more fatigued than normal, or she's now unable to she hasn't been having her menses over the past couple of months, then you know for a fact that it's going to be Sheehan syndrome. And the question in your mind, you're probably asking, well, I thought you're not going to have your menses within a couple months following pregnancy due to the fact that you have increased levels of prolactin. That's true, but they will make it clear in the vignette, okay, she's now about like 6 months post-pregnancy and she still hasn't had her menses. And she stopped lactating. Okay, so if you're not lactating, then you should be having your menses. But if you're not having your menses, then you should be lactating. So keep that in mind. If neither of those are occurring, then she might have Sheehan syndrome. And the patient is always going to present with that classic vignette. With postpartum hemorrhage, they come in with fatigue. And they might not even tell you about the postpartum hemorrhage portion, but they'll come in with fatigue. They're not able to lactate. They're having amenorrhea. And you'll know for a fact that it's going to be a Sheehan issue. Okay? I promise. The vignette's really easy. Another one is pituitary apoplexy. All that is just sudden hemorrhaging of the pituitary gland. So it just ruptures, essentially. And what the patient's going to experience is impaired extraocular movements and severe headaches. So if you see a patient with severe headaches and they can't move their eyes outward, they have extraocular movement abnormalities, then you know that it could be a pituitary apoplexy, and they could present with symptoms that lead to, or that present similarly to undersecretion of pituitary hormones. All right, so just keep that in mind. They like to ask about the CN3 palsy, which is the impaired extraocular movements. All right. Lastly, they asked maybe one question on empty cellar syndrome. You just have to know that it's located, empty cella is within the name, the sella tertia, okay? It lies within the sella tertia, okay? That's the question that they asked. I'm almost positive. Next is acromegaly. Acromegaly is just excess growth hormone in adults, okay? And the typical presentation, once again, is going to be, doc, my gloves and shoe sizes are increasing rapidly. My rings no longer fit. My gloves don't fit. My fingers are becoming really long. I have to buy new shoes. That is all telling you the same thing, that the patient is having acromegaly and it's excess GH production, probably secondary to a pituitary adenoma that is releasing that growth hormone, okay? And so you're also going to see like hyperplasia of articular chondrocytes, synovial hypertrophy, and it can lead to like an increase in skin tags and napes on the neck. You have larger tongue, and you're going to get like frontal bossing. You have coarse facial features, so they'll see like a large jaw, large nose. They'll have impaired glucose tolerance, insulin resistance, secondary to the effect of growth hormone, leading to an increase in insulin growth factor, IGF, insulin-like growth factor, I should say. And so you get insulin resistance. And the most feared complication, because it's the most common cause of death in patients that have acromegaly, is heart failure with preserved ejection fraction. So they get hypertrophy of the heart muscle, which is not good. All right. They also want you to know that you have an increase in GH in children will not lead to acromegaly. It will actually present with gigantism, and that's just an increase in linear bone growth overall. So just keep that in the back of your mind. But acromegaly is the easiest thing to spot. So keep in mind that large tongue, the coarse facial features, the glove size and shoe size changing, the rings no longer fitting, the hyperplasia of the articular chondrocytes with synovial hypertrophy, and that feared risk factor of heart failure with preserved ejection fraction causing ventricular hypertrophy. Lastly, they're going to ask about diagnosis. I remember, I think, a question on one of the NeoMed exams. They asked a really great question about how can you diagnose a patient with acromegaly, and they're going to try to throw you off. And one of the answer choices was growth hormone. You test the levels of growth hormone, but actually, what you test the levels of serum IGF-1. Okay, and the reason behind that is because it has a better serum lifetime, I guess I should say, for lack of a better term. You can see IGF better in the serum, and it lasts longer within the serum. GH is more pulsatile. Okay, so definitely check IGF-1 and know that that's how they diagnose it. They don't check GH for acromegaly. But that's all for hypopituitarism and acromegaly.